Already recording? Okay.
Okay, so I'll start with the chief complaint. So this is a 48-year-old female with left-sided chest wall pain.
What pain again?
Chest wall.
Hi, Jane. I'm taking the cue from you that you're muting that you'd love for us to discuss here, which I think is awesome, and a sign that you've been to many a VMR to know when to pass on the mic. And it's very intriguing that you're choosing to stop here, because I think that the immediate reflex when you hear chest wall pain is to take a breath and relax, because the moment the patient utters the word chest pain is the moment that you think of some very sinister causes. But as soon as the chest wall is invoked, that can give you a moment of peace, because you're like, well, if the chest wall is involved, then I need not worry about all the visceral structures, because they tend to span the chest wall. That, of course, is only partially true, as is the case in medicine, with the idea that some pleuritic diseases can actually masquerade as wall pain. In fact, the pleuritic component of many diseases can extend to actually irritate the chest wall and cause pain with palpation. The most common example that I've seen is actually a pulmonary embolism with lung infarction. You infarct the pleura, and both the parietal and visceral pleura, and it actually, when you press, it hurts. So I think in this situation, we're going to have to engage all sinister causes of chest pain, despite the fact that there appears to be a superficial component to the disease process, because there are no myths. But also some of them, namely the pleuritic ones, actually can characteristically present with disease that extends into the chest wall. This also is a good time to highlight that even diseases of the chest wall can be pretty morbid and deadly, such as a rib fracture that's pathologic from cancer, or disseminated zoster with extracutaneous manifestation. So often this case will lead to a benign conclusion, one in which the patient can expect to feel much better pretty quickly. But that's a conclusion that has to be reached meticulously and thoughtfully through all the visceral complications and also the morbid superficial complications. Prof, has anything to add before we move on? I think that was a 0. All righty, Jane, back to you.
All right. So I'll go through the HPI and the review of systems. She reported that about 1 week prior to presentation, she had tripped and fell on her left side and injured like her left flank. She had felt sore in that area for about a day. She took some ibuprofen and that helped with the pain, and it resolved within a day or so. And then about 1 week later, a night prior to presentation, the pain had acutely worsened. And it made it difficult for her to breathe because of the pain. So she said that the pain was 10 out of 10, sharp. She did say that it radiates from her left flank kind of to her upper abdomen and up to her chest as well. And then in terms of review of systems, she denied any fever chills, no cough or hemoptysis, no palpitations, orthopnea, PND, leg swelling, no recent travel. And I think I'll stop there unless you would like.
No, that is great. Jane, are you muted or did you freeze?
Like more information.
Oh, there you are. Okay. Oh,
did some of it not go through?
no, it all came through. Thank you so much. I think this is a great place to stop. And it's a fascinating case. So we don't really have the background data that helps influence how we interpret the foreground data that Jane has carefully presented. But the reason I find this fascinating is that I think we've all probably have experienced a fall in our lives. And if you think about it, generally in a healthy individual, I'm not sure if this patient is postmenopausal or not, but quite young, a fall shouldn't really lead to symptoms beyond a week. And already that is enough to consider some sinister causes of pathology here. The first thing the mind wants to do is it wants to blame this patient's presentation on the trauma that was associated with the fall. But that doesn't really add up because a week has gone by and now the patient is experiencing symptoms. So there's two possibilities here. One possibility is that we're dealing with a complication of the fall in the form of a rib fracture, in the form of immobility and clot. You can create any, hypothetical scenario. Another reasonable hypothesis is that this trauma is not really related to whatever is going to manifest, but sort of unveiled a disease process that was brewing that has yet been brought to our attention. The thing that helps distinguish between these two possibilities is if the patient can point to exactly where the pain is, then that's a real high pretest probability that you're going to have something anatomical there. It's very rare for someone to point to a single spot on the rib or the chest wall and say it's painful. Then you take an anatomical approach and you say, is it the bone? Is it the cartilage? Is it the intercostal muscle? So that's where my mind is. And we're not getting much flavor for, systemic symptoms. So it really seems at point blank, until we get additional data, we're dealing with a non-inflammatory post-traumatic complication. And that's sort of how I would frame it. Interested in hearing from Robbie as to any other thoughts here.
Absolutely nothing. I think that's superb. Yeah. Jane, tell us more, please.
All right. Yeah. Okay. So past medical history, she has a history of hypertension. She has menorrhagia, and that's kind of resulted in this chronic anemia that she gets iron infusions for. She also has a history of large uterine fibroids. And that's pretty much it for medical history. For surgical history, she has had a laparoscopic removal of her fibroids in the past. And she does have one scheduled in September for another removal of a large fibroid. She's had a breast implant that was 6 to 8 years ago. And then in terms of medications, she's taking atenolol 100 milligrams daily and amlodipine 5 milligrams daily. And then in terms of health-related behaviors, she does smoke tobacco, about 6 to 8 cigarettes a day. And she started in college on and off, and then has really picked up again in the past 4 to 5 years. Otherwise, no alcohol or other drug use. And then no allergies. And in terms of family history, a lot of members in her family have hypertension. She says basically everyone in her family has hypertension. She has a grandmother who had breast cancer, an aunt who had breast cancer, and then a grandfather who had a stroke. But he was more than 70 years old when he died due to the stroke. Let me know if I need to repeat anything.
Yeah, Jane, this is awesome. I think the question that you're asking here when you're taking care of this patient is, how are you going to move the case forward? And I think that in somebody with traumatic disease, at least a working hypothesis of traumatic disease, the questions that tend to be pertinent are, do they have any vulnerability for any of their anatomic structures to have more severe consequences than anything else? So I think what I was studying this history for was any risk factors for osteoporosis beyond age and gender. And I don't think that we encountered any. And so that's studying the bone as having a vulnerability to have a more disease beyond anything else. And then the muscle can have propensity for disease beyond what is expected in patients who bleed, because most people who have a hematoma actually have an intramuscular disease process. And so we got a little bit of a hint of that initially with the fibroids, but then that went away when we with the menorrhagia, but went away when we realized that it was an anatomic reason for menorrhagia, namely the fibroids. But then you told us something else, which is that she has a breast implant, and that's potentially evocative of the possibility of implant rupture, and that implant can, as a result of trauma or other consequences, actually break and cause significant pain. So those are the only things that I'm tracking now. I think the exam will be incredibly illuminative, as it often is when somebody has a superficial complaint, be it in the chest, the abdomen, or the extremities. So those are nothing for bone, nothing for muscle, but maybe the breast implant is something to pay attention to. Prof. Rez, any other thoughts?
A 0.
All right. Jane, you're silencing us. I don't think this has ever happened before, where only one person is reflecting. You're keeping your cards very, very close to your chest. Can't wait for them to be revealed.
All right, great. Okay, so vitals, her temperature was 99 degrees Fahrenheit. BP was 127/79. Let's see, heart rate was 88. Respiratory rate was 20. And then her O2 sat was 98% on room air. And then moving on to the exam, in general, she wasn't in no acute distress. HEENT was all normal. In terms of cardiac, so I guess cardiac / chest, there was no bruising or evidence of trauma on her left-sided chest wall. She did have some tenderness to palpation on the left anterior upper ribs. Otherwise, in terms of cardiac, regular rate and rhythm, normal S1, S2, no murmurs, rubs, or gallops. For lungs, clear breath sounds bilaterally, no wheezes, rales, or rhonchi, no dullness to percussion. And then in terms of abdomen, no distension, no bruising, abdomen is soft, some left upper quadrant tenderness, mild, otherwise no other findings. And then neuro and extremities were all normal.
Yeah, so very challenging case to dissect up front, because we still don't have our pivot point. And I'm really excited to see what the imaging shows. You have to interpret this heart rate with caution, because this patient is on atenolol, but I'm not getting much flavor for an inflammatory syndrome. And despite there not being anything external, it does not exclude pathology or trauma of an internal structure. And I think the way to think about any type of localized pain is to imagine an arrow or something piercing through the skin and asking the question, what structures can it come in contact with? And if you go through that exercise, and we really evaluate the patient's wall pain in that context, in that light, you say, okay, could it be the skin? Well, we're not really seeing anything on the skin. Can it be a nerve? Of course, at the end of the day, the nerves are what signals the brain that there's pain, but there has to be something that's irritating those nerves. Could it be the muscle? Possibly, but boy, it's a bit challenging to draw that conclusion. Then you go deeper and you just start thinking about organs that are on that track of where that pain is, whether it's the kidney, whether it's a vessel like the aorta, you name it. But, and I'm really interested to hear what Robbie has to say here. But right now, the way I'm framing this is just a middle-aged woman who had a fall, is experiencing pain, and I need to image to evaluate for any fracture or trauma. I'm just not getting that much in terms of vascular badness, and I'm prioritizing an anatomical problem. I think the point that Robbie made is a very good one, that if there is a fracture or an anatomical sequela of this fall, the question is, why would such a young person have, is the anatomical change out of proportion to what we would expect? Then that raises Pandora's box of why is the bone or the structure vulnerable. But I'm just searching for stuff. And I think in this particular case, moving on to imaging would be extremely insightful. But Robbie, would love to hear, like, you're in the ED, you don't have imaging right away, like you have to go through these steps. So what Jane is doing is really challenging us appropriately as clinicians. How are you thinking about this in that beautiful San Francisco emergency department?
I think the emergency department just heard you, so it appreciates your flattery. Yeah, let's put this context in real life. What Jane is doing is slowing down the tape for us to analyze and dissect everything. In real life, this data would be given to you in about 2 to 3 minutes. So you would walk in, get a quick history, do a quick exam, and do a quick chart review. So we're still in the first 5 minutes of an evaluation of a patient like this. And the only real decision-making that you're having to do is what do you do with the patient in terms of, do you put her in a bed and get an IV and give some IV pain medication, get some blood work, or do you ask her just to wait in the waiting room until somebody can see her with more time? Or do you ask her to get some imaging and see what that shows? And I think in a patient like this who has normal vital signs and tenderness, you probably say, hey, I'm not sure what's going on. Let's get an X-ray, a rib film, to see if there are any rib fractures and go from there. So that would probably be your initial branch point. And if you don't find a rib fracture, you're in trouble, because rib fractures are a very ready explanation for what's going on. Most people with rib fractures have pain for months. It really is a very hard condition to heal. And if she doesn't have rib fracture, you have to explain why she's still in pain, as Prof. has alluded to. It's very unusual for her to still be in pain. So at that point, you'd probably be in a tricky spot where you might either image further or try symptomatic therapy with return precautions. So I think the key step is there a rib fracture or not? And if there isn't, the clinician up front has a tough call to make about whether or not you need to dig deeper or use the test of time. All right, Jane, back to you.
Can I just say something? Every time you say like dissecting the case, I'm like, if this ends up being a dissection, then we can title it a dissecting case. And then you're like, you got to dig deeper. I'm like, if it's a deeper structure, it could be like a deeper differential diagnosis.
We're full of
Buzzwords, my friend.
Accidental puns and buzzwords.
I love it. I love the discussion. And yeah, I think, Robbie, your reflection that this probably took about 5 minutes, that's very true. Like, I went down to take her history and it probably took me like 10 minutes to get all of this history. And so at this point, we were really trying to figure out what was going on, and we were stumped too. So I will give you the labs as well as some of the imaging. I'm going to leave maybe some of the imaging for the next aliquot. We'll see. Okay, so for labs, white blood cell count was 8.9. Hemoglobin was 8.2. Hematocrit 28.2. MCV was 70.9. Platelets 238. then in terms of her complete metabolic panel, everything was normal. We got a troponin, which was negative, and then COVID negative. She got an EKG, sinus rhythm at 74, heart rate was 74, no acute ST changes. And then we got a chest x-ray, showed no fractures. There was a small left pleural effusion, but otherwise everything else was normal.
Ooh, I think it rings true to never let the sun set on a pleural effusion. You know how weird it is to get a pleural effusion? It requires your internal body's compensatory mechanisms to fail. So I think that I'll leave the data for Prof. Rest to analyze, including his thoughts for left pleural effusion. But here's your pivot. You found something to push you to go further, because it is highly abnormal to have a spontaneous left-sided pleural effusion, and highly abnormal to have any pleural effusion of any cause in the absence of heart failure. So you found your pivot point to push forward, but before you do that, you should probably analyze the whole picture to be more thoughtful about what you do. So for that, I'll pass the mic to Prof. Rez, see what he thinks.
Yeah, thank you so much, Robbie. The anemia is microcytic and is consistent with this patient's history of menorrhagia and iron deficiency. Again, I scanned all the labs, the vitals for any signal to inflammation, because that's going to be a very important question here. Is this patient inflamed or not? The way to approach pleural effusions is like the way you would approach lower extremity edema. You ask the question, if it's transudative, then it's the three organs on the line: the heart, the liver, the kidney. But she does not have heart failure. She does not have cirrhosis. The kidney can be renal insufficiency, which she does not have, or it can be nephrotic syndrome that can lead to third spacing of fluid. And that's very difficult to tease out. And you eventually do need to look at the UA to see if there's any evidence of albuminuria. If there's inflammation, then you apply the IMATE mnemonic: infection, malignancy, autoimmune. So how much progress can we make here? You know, when we were at that first stage where this patient had the fall and then was experiencing pain subsequent a week later to the fall, we wondered, is this related to the fall in the forms of like a fracture, or did it just unveil another process? And that's the camp that we're in now. So what I'm really hoping is that we can actually sample this fluid and apply Light's criteria to frame it as transudative or exudative. And Light's criteria rarely misses an exudative cause of pleural effusion. It may misclassify transudative as exudative, but it rarely misses an exudative cause. So where am I right now? We need to sample this pleural effusion. And Robbie, I don't think the heart, the liver, the kidneys on the line, and I'm not getting much in terms of systemic inflammation that would prompt me to think of an autoimmune process like lupus that causes serositis. Cancer is always on the DDX. She has a family history of cancer. And so we must, consider that strongly, but I'm not getting an infectious or autoimmune flavor from this case. And then there's some anatomical issues that can lead to pleural effusion that are rare. But Robbie, I want to throw this back at you, like with her history and everything we have, like where are you in the sort of pleural effusion, assuming we can even sample this fluid?
No, I completely agree with you. I think that I'd be proceeding full throttle down the pathway you just outlined with some attention to the fact that this pleural effusion may be misleading, because I think that we often say pleural effusion means disease of the pleura or the adjacent lung. but sometimes that disease can emerge from the belly. And the best example is hepatic hydrothorax on the right. And less common but important examples are a splenic hematoma and a perinephric hematoma on the left. So I think I would probably have a hard time deciding, in addition to trying to tap the suffusion with a bedside ultrasound, to see if I needed to scan the abdomen and pelvis. And honestly, with the trauma in the background and the flank pain in the background, I don't have that expertise. Even though this is an emergency room, we don't have that trauma expertise. And I'm really curious how a trauma experienced doctor would rationalize through this case and say, do you need imaging or not? But probably because of that lack of experience, I'm more inclined to cover my bases and be more conservative. And so I think I'd probably try to sample the fusion first. And I would probably get a CT abdomen pelvis, but that might be overkill. But better to do more when you don't know rather than to do less,
I absolutely love that because, when we went through that exercise, there wasn't anything strong. Like there's no strong signal to inflammation and there's no strong signal to transudative cause. So thinking outside the pleura, I think is a really good approach. So I think a CT scan looking for trauma, that makes a lot of sense to me.
100%. Whenever you tell an ER doc, what do you want to do next? The odds of it being a CT abdomen pelvis are so high, like, come on. All right, Jane, tell us that there was no CT ever obtained and we didn't need it. Please, please.
That was exactly what the ER did. They did not get a sample of the pleural effusion. They went straight ahead with a CT PA and a CT abdomen. So the CT PA, I'm not exactly sure what their rationale was for getting that. But I think because she did have severe pain with deep inspiration, they decided to go ahead and just get that. So for the CTPA, the main findings were she had bilateral upper and lower lobe pulmonary artery emboli, as well as the small left pleural effusion that they saw in the chest X-ray. And then in the CT abdomen, they saw a 12 centimeter heterogeneously enhancing mass on the left side of the uterus, which is consistent with a large fibroid. And they also saw the bilateral lower lobe pulmonary emboli, as well as the small left pleural effusion.
Wow. So now we have an answer for what's causing this patient's pain. And really, I think that in reflection, with the pleuritic chest pain, one-sided, it fits really well for a pulmonary embolus. Now the question is, why does she have a pulmonary embolus? And in most patients, you really don't necessarily have to answer that question, meaning you don't have to do a thorough hypercoagulability workup. But in this individual who's so young and has such severe disease and has this background of cancer, I think it's critical to look for a secondary cause of hypercoagulability. These clots are not because she had a fall and wasn't moving. This, to me, would prompt me to just search for a cancer. And how would that manifest? It could be in the form of a PET CT scan. It could be in the form of analyzing that large mass that they're labeling as a benign mass fibroid. But yeah, I think that cancer is probably leading the DDX, and then you can think about other stuff like APLS and other hypercoagulable disorders. But Robbie, any thoughts as to what you would do next or what's driving these thromboses?
Yeah, guys, think about this. You're taking a patient who said, hey, I fell on my left side of my chest and it hurt and I'm still in pain, and you're telling her she has a pulmonary embolism. It's incredible. You have to be very, very humble about this diagnosis. And here we're diagnosing pulmonary embolism without dyspnea, tachycardia, hypoxemia, which is really mind-boggling. And I think it goes to show you that it really is, there's a reason why it's one of the most misdiagnoses in this country, and a reason for one of the most common reasons for malpractice lawsuits. I think like it'd be very, very hard. If you take this pleural effusion out of this case, it becomes much, much harder to diagnose this. So I think it goes to reinforce that initial pivot that we planted ourselves in, which is we have to go through that journey of the sinister causes of chest pain. And the one sinister cause that deserves excess consideration in somebody with chest wall pain is a lung infarction. And I suspect that's why she's hurting, is part of her lung, whether that's apparent or not, has been infarcted. So now this case is a great reinforcer of that concept, that even though we often end up with benign diagnoses in this space, the most common visceral cause of chest wall discomfort is a PE with infarction. And here, what were your clues to pick up from making sure you're not being misled? I think it's a pleural effusion. And I wonder also if a D-dimer might have been helpful in this situation, if that was available, because that would probably push you over the edge. In terms of why she has it, geez, I think it's so tricky to not worry about a malignancy, especially in the context of the fibroid mass and how extensive her disease is. But often, if the malignancy is not staring at you and is overtly obvious, it's often can be a little bit hard to find. I think the question is, do you screen for hypercoagulable conditions like APLS or hyperhomocystinemia or the genetic diseases? And I think that's anybody's. I think that the guidelines are very complicated to analyze, but she probably now needs an assessment for whether this is a moderate risk pulmonary embolism or a low risk pulmonary embolism. And the way you do that is you would look at the CT to see if there's evidence of right heart strain or not. You would get an EKG and look at it more closely to see if there's right heart strain, and you would obtain a BNP and a troponin. I know we have the troponin, but the BNP may be helpful. Most PEs end up being low risk PEs in terms of their hemodynamic consequences. And so a patient like this is often discharged on anticoagulation. Yeah, it's very, very humbling, and kind of keeps you on your toes and makes you wonder how often you've missed a PE because somebody, you don't have the pleural effusion. I would have missed it for sure. Yeah, Jane, what was this like? What were your feelings taking care of this patient, and how? And yeah, just tell us more how it felt to take care of this very tricky case.
Yeah, so I think I went through all the emotions and thoughts that you went through as well. It was really humbling because, like her vitals were completely normal. She didn't have any shortness of breath besides, having the pain from breathing deeply. So it was, and then paired with kind of the history of the trauma a week before, that kind of, distracted us a little bit. But after getting the imaging findings, that was really interesting to us again, because, she's young, and why is she having all of these clots? And so we got a pulmonary consult, and they agreed that, the pain is most likely because she did have some infarct because of the emboli. And we ended up doing bilateral lower extremity Doppler ultrasound, and it showed multiple clots in her lower extremities. And so the pulmonary emboli is most likely from that. And so we started her on Eliquis, and the pulmonary attending, he was trying to figure out why she would be so hypercoagulable. And one of his theories was that it could be because of Thurner Syndrome. And I think we talked about this a couple of VMRs ago, but basically Thurner Syndrome usually is because you have compression from like the common iliac artery, the right common iliac artery on the left iliac vein. And that can cause kind of turbulent flow coming back up and can increase kind of clots in the lower extremities. In her case, he was thinking that because she had this large fibroid, that could be what's causing this Thurner syndrome. And I did go back to talk to her a little bit more, and I did find out that she has had 2 miscarriages in the past, and she doesn't have any children. And so there was the possibility that she did have, antiphospholipid syndrome, something like that. So yeah, so I think it was very interesting to kind of think about this case, because, she's young, and it was pretty, it was easy to miss. If we didn't get that imaging, I don't think we would have figured it out. And I think the other interesting part was also that she did have this history of menorrhagia. And so in terms of treatment for her, putting her on Eliquis, that's going to worsen her menorrhagia. So we did get an OB-GYN consult, and they recommended that she get her, so she was scheduled for the fibroid removal in September. So they recommend that she get that done as soon as possible, to decrease her risk of, menorrhagia because of the fibroids. And then also they recommended that she get depot shots to help with the menorrhagia as well. So I think that was another important learning point for me, was that, you have these guidelines for treating pulmonary embolism, but you still have to think about their history and kind of individualize their treatment because of that. So, and then in terms of hypercoagulability workup, that was definitely something that we wanted to do for her just because of her history. But that's, I found out that that's something you have to do like 4 to 6 weeks after the thromboembolism event. So that was something that she would have to do outpatient, and I haven't followed up with her since then, so I don't know if she ever got that done. But yeah, so that was the case.
Absolutely awesome, Jane. Can I ask, how did it feel to present it here?
I was very nervous, but everyone's very supportive, so thank you so much. But yeah, this was really fun, and thank you for the discussion.
Yeah, no, absolutely. You've been such a pivotal part of VMR for so long, so it was a real special treat to see you present. What do you think drives that anxiety and that nervousness?
I don't know. I think, I hope that the case is interesting and that people can learn from it, and that I'm not just, I don't know, shooting things out there that don't make sense.
No, not at all. Not at all. I think it's absolutely humbling how these kind of cases where you are like, people are like, where is this going? Like, there's nothing sinister going on. And then boom, you're like, oh, multiple lobar pulmonary embolisms are really keep us on our toes. And they're different. They're very different than the usual, like tuberculosis everywhere kind of VMR. This is a very, very realistic case that arms you with bread and butter. It really is. There's no esoteria here. And yet many people would have been stumped by this case. So I really, really appreciate you bringing it here today. I think it is very enlightening. And then also the deeper reflections about the complicated management reasoning in a patient like this who's anticoagulated but is bleeding is just another level. And then also the nuances of picking up subtle hints as to what might be going on with the APLS and the May Thurner is awesome. Yeah, so really, really marvelous job. And also, before I pass the mic to Kirtan, do the teaching points, wanted to thank everybody who showed up and turned their video on. It really makes it another level. So really, really appreciate you, Maribel and Syed, of course, Nalayan, Ariel, hello, and Jacqueline, nice to see you all. Thank you for being hyper present. And thanks again, Jane, for an awesome case. I'm excited because I haven't heard the brilliance of Kirtan on teaching points for maybe a week or so or beyond that. He's making it a trifecta with facilitating on Wednesday, Thursday, and now teaching us today. We're really excited for the Kirtan treat. Take it away, my friend.
Yes, so I just wanted to thank first Rabi and Reza for awesome discussion. I mean, they got the diagnosis in the first report itself. Like Reza discussed that how trauma can lead to hypercoagulability, and because of stasis and everything, and that could lead to pulmonary embolism. And Rabi immediately jumped to the possibility of pulmonary infarction leading to the pain. And I also wanted to thank Jane, because Jane thinks that she was anxious. I mean, it was such a flawless presentation. I don't know that if she is anxious and presenting in such a manner, what will we do when she is confident, right? I mean, I am definitely going to learn from her how to present the case, because very calculative, very calm, there were no glitches, so very, very flawless. So thank you, Jane, for that. Now, talking about the first aliquot, that how we can approach the chest pain. So we have a beautiful framework that is it coming from the thorax or it is coming from the extrathoracic part. And like if it is indeed coming from inside the thorax, then what are the anatomical structures that we need to consider? So we have the heart, we have the lungs, we have the mediastinum, and in the mediastinum, you also have the mediastinal lymphadenopathy. So, lymph nodes are there. So that can also lead to the pain. Apart from that, the membranes, so like pleural membrane, pericardial membrane. Then talking about the chest wall anatomy, then we have the costochondral cartilage, we have the intercostal muscles, we have the cutaneous nerves, and then we have the extrathoracic causes. Like it could be coming from the neck, it could be coming from the abdomen. So that is how we can approach the chest pain. Then talking about the second part, that how we can put the history into the perspective. So in our case, the trauma was the highlight of the case. Like we are talking about the trauma in each and every aliquot and trying to link it to our findings. So how we can explain the trauma? So, rib fractures, so Rabi mentioned that maybe the patient has osteoporosis or any other risk factors for osteoporosis. And that's why she developed the rib fractures because of maybe a seemingly normal trauma, which is causing the pain now. Apart from rib fractures, we can also think about the muscle hematomas. So, when you have got intercostal muscle hematomas or abdominal wall muscle hematomas, you can get the pain. And then you have compartment syndrome. So like in one of the journals I read that compartment syndrome is not just common in the peripheral muscles, but sometimes it can also happen in the axial muscles. So like in the spine and around the ribs, if you have the collection of blood and if it is distending the fascia, then you can have abdominal pain, which is radiating all around. So we have to consider that. Then intraperitoneal hemorrhage. And our dear friend Franco has presented many cases on VMR in which you get the spontaneous arterial dissections and that leads to pain. So that is also along the path of what Rabi was mentioning, that maybe the patient can have splenic hematoma, maybe the patient has perinephric hematoma or some sort of retroperitoneal hemorrhage, which is causing this severe 10 out of 10 pain, which is radiating all through and through. So that is important, how to put trauma into perspective. And then what to make of apparently normal physical examination. So Rabi taught us that we need meticulous evaluation to make sure that visceral organs are not affected. So maybe the signs are not there on the outside, but maybe the organs are affected, so we can't be sure. And again, having an anatomical approach like we had in our first aliquot can help us guide how to move ahead. And then imaging studies came into light that we had the pleural effusion, and as it turns out that was the pivotal point and not the trauma part. So once we got the pleural effusion, we went down the normal evaluation pathway, that whether it is exudative, whether it is transudative, and if it is indeed transudative or exudative, then what are the most common causes. And as we know that pulmonary embolism is one of those causes which can cause either of effusions. It can cause either transudative or it can cause even exudative. It can even cause hemorrhagic effusion because of the pulmonary infarction. So that was very important. And last part, that how we can put all this together. So, this is a very humbling diagnosis, because this is what I learned during my med school, that if someone has myocardial infarction, we immediately think, okay, 10 out of 10 severe retrosternal chest pain. But if someone has renal infarction, then we will never consider it as a cause of abdominal pain. So similarly, it is true for the pulmonary infarction. I mean, infarction is infarction. Cell death will lead to pain regardless of whether it is myocardium or it is any other tissue. So you can get splenic infarction and severe left upper quadrant chest pain. You can get hepatic infarction as in Budd-Chiari syndrome, and you can get severe right upper quadrant chest pain. Same is true for lungs also. So if you have a severe chest wall pain, then we know that the pleural surface can be hit by the infarction, and that's why we are getting this severe pain. So my take home message from this case and what I learned was this part, that whenever you have a severe chest pain, consider the vascular causes, because infarction is the must not miss because of the morbidity. And once we have prioritized the infarction or the vascular part, then we can move to the other diagnosis and make our way ahead. So thank you so much again, Rabi and Reza, for amazing discussion, and Jane for presenting the case. Can't wait to hear your next case. I will definitely sign up on that day when you are presenting the case.
Absolutely superb, my friend. Thank you for such illuminating and crystal clear teaching points. I think you're getting a lot of love from the chat, so make sure you look at that before you go. All right, everyone. We'll hope to see you next time. Unfortunately, we're not doing VMR tomorrow, but we'll see you back the next time. Take care.